good evening again. My name is Diana Artene. I am an oncology dietitian, and tonight I will briefly cover sarcopenic obesity, impact, causes and solution for your breast cancer patients. But before I do that, as I said, to have a little taste of what oncology nutrition actually is, I would like to invite you to please play with me a little game and really try to do it, at least try. Take your phone, okay? Turn it down, okay? And leave it like that for the next 45 minutes. That's the game, and it has nothing to do with the phone, but just play with me and I will tell you in the end what is it about. So let's start. At ASCO 2014, there was a presentation of a meta-analysis that showed the world what most of us working in oncology already knew. Obesity worsens breast cancer prognosis, increasing recurrence, breast cancer mortality, and all-cause mortality risks. So the nutritionists worldwide gathered their forces to boldly go where no one has gone before, and like in the Nike commercial, let's just do it. And there are three main ways to lose weight: eat less, low carb, high protein, and the ketogenic diet. And I would like to start with the eat less theory, which is the first solution offered against breast cancer obesity. And in theory, you eat 25% less, then you will lose 25% weight, which sounds pretty logical, but sadly, in reality, we must carefully describe what less means from the eating less mantra. The reality is not at all what most believe. Energy expenditure following weight loss by starvation or by eating below what the internal organs and the brain needs actually leads to a metabolic over-adaptation and causes a return to the original weight. And what we need to make the patient do is to lose fat without losing muscle. Sarcopenic obesity is defined as increased adiposity based on muscle loss with or without increased body weight. This means that it can happen both in normal weight and in overweight and obese patients. And if you just lose weight but not fat, you create an oncology detrimental impact by worsening sarcopenic obesity and by deregulating body sensitivity to insulin, and also by creating or amplifying liver steatosis and dyslipidemia. To avoid sarcopenia, we need to maintain the daily muscle protein balance by counteracting the breast cancer treatment impact on the muscle mass. And we have this daily muscle protein balance, and on one hand we have the muscle impact of the treatment, and on the other hand we have the protein intake, and also we have the physical exercise. It is important to know that the oncology treatment itself generates muscle loss and increased adiposity even in patients who do not overeat and who are normal weight by BMI. And we only see the obesity as weight gain in patients with low protein intake and excessive carbohydrate intake. And Chan et al. Warned us that obesity defined as increased body weight has a detrimental impact, but sarcopenia is as strongly associated with decreased survival as high adiposity. And he was not the first researcher that showed this. In 2002, we already have a systematic review. I think it was published in the Journal of Clinical Oncology, and it was based on 158 studies already available in 2002 associating obesity with a worse prognosis. And if there is only one thing that you will remember from this webinar, please let it be that breast cancer patients don't have to lose weight for the sake of weight loss to improve their prognosis. They have to lose fat without losing muscle. If they lose weight by muscle loss, they will only obtain worsened sarcopenic obesity that you might not initially see if you're only focused on decreasing total body weight and not on improving body composition and eating behavior self-control. The second solution offered against breast cancer obesity is the ketogenic diet, in the context that let's say smart people diagnosed with breast cancer today still believe popular assumptions that incriminate animal protein in cancer etiology, ignoring that protein intestinal digestion exists. Other smart people started to take into consideration that malignant cells prefers glucose like any other cell inside the human body. And ignoring the studies pointing an accusatory finger towards the link between an excessive fat intake and breast cancer etiology, ketogenic scientists and worldwide chronic dieters embraced the ketogenic diet proposed as a cancer metabolic treatment. Because cancer cells are dependent on aerobic glycolysis to survive due to the fact that their mitochondria don't work that well, then because tumors feed on sugar, thus excluding carbs slows down tumor growth and improves oncology treatment, and because excluding carbs helps with weight loss. But let's underline the fact that is a high-fat diet, 70–75% fat, and not a high-protein diet, and it brings only 15 to 20% proteins, which is not enough to counteract oncology in treatment impact on the muscle mass. So it's not enough to counteract sarcopenia. And all seems nice and rosy when we think about weight loss as total body weight decrease, as ketogenic diet looks at first as weight loss effective in breast cancer patients as in general population. Just that any diet, this or any diet on the planet works only as long as you follow it. And the metabolic inflexibility associated with excluding carbs leads to, when you go off it, to fast weight gain, to disturbed appetite, to emotional eating and yo-yo dieting, on top of liver impairment because the hepatocytes do not have the enzyme needed to metabolize ketones. It leads to nutrient deficiencies and overall increased fatigue because ketogenic diet excludes most foods high in vitamins and minerals. And please let's not forget, I underline again that it does not bring enough protein to maintain the daily muscle protein balance needed to avoid sarcopenia. Another problem is nausea, because eating all these fatty foods, even in healthy people, makes them so sick of eating that they kind of gradually start to avoid eating altogether, spiraling back directly to the eat less category of people that amplify sarcopenia. And another problem is constipation, because it's quite low in fiber, and constipation can be even more amplified after the days of chemotherapy administration. So, before recommending this diet to a single patient, we need to carefully assess, do we want weight loss at all costs? Are we willing to hurt the patient? Is the patient physically and, let's say, mentally fit enough to follow such a restrictive diet long term? And does she has the financial resources to do it? Because also we work, I think all of us, also with not so rich patients. So, and all this talk about side effects is just a talk, because it's not about the real side effects. It's about the perceived side effects by the patient. And I just had this week a breast cancer patient. She's doing radiotherapy, and she has like 7–10 liquid stools per day, and she was convinced that her severe diarrhea was a radiotherapy side effect, while she actually has Clostridium infection. And I give you this example because patients' reported outcomes are reported from the patient's understanding of things, and sometimes the patient might not differentiate between the treatment side effects and the diet side effects. And moreover, this, let's say, lack of ability to see the shady 50 shades of gray is even more accentuated if the patient is told that the ketogenic diet is a metabolic treatment for cancer. And if you excuse the technical term, I think we all know a patient will eat shit if she believes that this will cure her cancer. And please avoid using their confusion, anxiety, and desperation to promote extreme nutritional recommendation, as any of us could any day be in their shoes tomorrow, as confused, as scared, and as desperate. The way we present things to patients has to respect the available data on oncology safety. And the available data shows that breast cancer cells, mitochondria work quite well, metabolizing fatty acids and ketones, and some cancer prefer to use fatty acids and ketones, among which breast, ovarian, and prostate cancer. The more aggressive the cancer, the higher its metabolic adaptability and the better the mitochondria function. And we also have data showing that ketones themselves can generate tumoral growth and metastasis. Another thing showed by the data is that although it is true that Otto Warburg showed in 1924 that we have these malignant cells not using their mitochondria and remaining in during aerobic conditions in just doing glycolysis, this was like a long time ago. And the Warburg effect was a huge discovery then. But however, like with everything in breast cancer treatment, scientific discoveries of malignant metabolism have continued, and today we know so much more about its complexity. We know that malignant cells can simply hibernate, doing nothing. Metabolic pathway called the Crabtree effect, through which the cancer can slowly grow in the body for years and years before we can actually diagnose it. Then, thanks to Pavlidis et al., we know that malignant cells can force nearby stromal fibroblasts to go into the aerobic glycolysis, and the fibroblast mitochondria become dysfunctional, not the malignant cell ones. This is called this is the image of it, you have it on your screens, the reverse Warburg effect. This effect was firstly observed in breast cancer, and it's one of the main metabolic pathways, proving that breast cancer tumors do not rely on sugar as they are not homogeneous tumors. Breast cancer is a heterogeneous malignant disease, and I put you here a study of 740 breast cancer specimens obtained from breast surgery that shows how complex these breast tumors were. And in this study, 40% of the samples presented aerobic glycolysis inside malignant cells, aerobic glycolysis meaning the Warburg effect. 7% presented it inside the fibroblasts, not in the malignant cells. 8% presented it inside both in the malignant cells and in the fibroblast, and 44% presented no aerobic glycolysis whatsoever. And what this shows is that malignant cells is just a didactic concept. As with any other cells in the entire human body, Malignant cells differ from one from the other depending on the type of tissue they come from. Then malignant cells coming from the same type of tissue differ from each other by the genetic mutations they have developed during carcinogenesis, by their localization within the tumor, and by the stage of the cellular replication in which they are found. That is why, please understand that the proper answer to the question, what is malignant cell, what does malignant cell eat, is malignant cells eat whatever is available. And this is important to understand because sadly, whatever is available actually means whatever is available. Malignant cells being able to survive by actually eating nearby cells. Under glucose starvation proposed by ketogenic diets, more aggressive breast cancer cells can either simply ingest nearby cells, living alive nearby cells. This process is called entosis, or make them die and then eat them, process called cannibalism. Cancer cells adaptation to glucose starvation is done through these metabolic pathways which worsen breast cancer prognosis. We have real studies showing that entosis and cannibalism, which actually you can see it on a histopathological exam as areas of necrosis, autophagy and necrosis, this shows worsened prognosis. And we also have to tell our patients that the hypothesis that the ketogenic diet has a positive impact on cancer patients is supported by case studies, and of course we have lots of preclinical data. But clinical trials on the subject are with a small number of patients, they have short follow-up, and many are done on various cancer patients, although we also have, let's say, only done on breast cancer, but most have inconsistent results. The current data state that there is no proof that a metabolic treatment for cancer exists, and the patients to whom this diet is proposed should be clearly explained that they are not, when they start the ketogenic diet during active breast cancer treatment, this brings them in a clinical trial, and they are exposed to the risk of a clinical trial, and by their evolution we will find out if these diets are safe or not. We don't know yet if the ketogenic diet is safe or not for a breast cancer patient. Based on the malignant metabolism complexity, we know today there are 0 ways in which we can starve malignant cells, and there is no diet that can cure cancer. Oncology nutrition is supportive care, not treatment. And the only diet that is scientifically proven to assist breast cancer patients during these breast cancer treatment stages is the Mediterranean diet. And the first solution offered against breast cancer obesity is a modified high-protein Mediterranean diet. And to counteract the Warburg, the Crabtree, the reverse Warburg, the cannibalism, and the entosis, the limiting of the carbohydrate intake needs to be moderate. And if in the general population we have a 55-60% recommended carbohydrate intake, in the breast cancer we just go a bit lower to 40. So it's not too low to not go into all these pathways that can worsen prognosis. And there are many interventional studies using this approach, and most share 2 common characteristics. The nutritional intervention must be built to avoid muscle loss. So whatever you tell your patients, just say, be sure that you have a proper protein intake and that you move a lot. This is what can counteract the treatment impact on on the muscles. If you don't say that, they will lose muscle even if they don't have to lose weight. And the second characteristic is that this diet, whatever diet you choose to offer to your patient, must be affordable, because we have to think of financial toxicity, and also it must be easy to implement at home on a long-term basis. And why? Because patients' compliance highly influence the nutritional intervention efficacy. And in the 3 years at the Oncology Institute of Bucharest during my PhD, I worked with 1,067 breast cancer patients, evaluating all treatment-specific factors, patients' lifestyle, eating behaviors, and comorbidities that I thought that they could decrease metabolism. I analyzed them all. And I also met countless non-compliance issues related to the adequate day-to-day appliance of my recommendations. And while younger patients kind of drove me nuts with the mid-billion questions about alkaline water, beetroot juice, dietary supplements, and the many diets they kept reading about on the internet, older patients surprised me with their compliance, following by the book any recommendation I give them. And I have to admit, I actually love my old patients. They are my heart, because they really listen to me. And I presented my PhD thesis at the ESMO Congress in 2018. And the conclusion was that in compliant patients, we can counteract sarcopenic obesity. It is hard, but it is achievable. And it is hard because there are both treatment-related factors and patient-related factors that influence oncology nutrition efficacy. And I will present this in a minute, but before I do, I want to mention another study presented at ESMO that year, authored by some of my colleagues. And these studies show that in healthy women, attaining a normal body weight without improving body composition does not improve women's health and does not prevent breast cancer. Normal weight women by BMI, but with excessive adiposity, having a higher breast cancer risk. Alongside with my colleagues working specifically in breast cancer nutrition, and after 6 years of working with more than 2,000 obese breast cancer patients under active oncology treatment, please allow me to state that in this patient's population, success is not total body weight loss. So we no longer believe that to counteract sarcopenic, the success of counteracting sarcopenic obesity is total body weight loss. We believe that during active breast cancer treatment, success is stopping fat gain. And why? Because to improve patients' outcome, we want to improve body composition, and we want the patient to have better eating self-control, not weight loss for the sake of weight loss, as even 10% weight gain can, after the breast cancer diagnosis, is associated with increased risk of overall mortality. And regarding the impact on chemotherapy, I will start now to present the impact on obesity, impact on breast cancer treatments. It decreases the chances of attaining a PCR to neoadjuvant chemotherapy. And we know this from a long time ago from MD Anderson Cancer Center, that we have a study analyzing more than 1,000 patients, and the patient with higher BMI obtained lower PCR rates. And it is not only about decreased neoadjuvant chemotherapy efficacy, but also about increased side effects. Obese patients having more neuropathy, more fatigue, and more anemia than their normal weight counterparts. So I start oncology nutrition from as early as diagnosis, and since neoadjuvant chemotherapy is more and more implemented, I actually work throughout the chemotherapy before surgery to help the patient to at least maintain and not gain weight during chemotherapy. This is very important, and I will later show you that it is possible. Regarding breast surgery, obesity associates an increased risk of persistent pain, complications, and lymphedema. And while we don't really know the exact mechanism through which obesity increases the risk of lymphedema, some researchers hypothesize that the compression exerted by the local adipose tissue injures the lymphatic vessels, which leads to fibrosis and even more fat being deposited on the affected area. Then this compresses the lymph vessels further, aggravating lymphedema parallel with patients' weight gain. So we don't only have the axillary dissection plus minus radiotherapy plus minus chemotherapy impact and all the other things like patient's hypertension and so on. We also have the fact that a fat arm, just the fact that the patient has a lot of fat in her arm, I don't think you can actually see me now. So if here we have a lot of fat, then this is just very important factor that increases lymphedema risk. And if the patient further gains fat during the after the axillary dissection, after radiotherapy, and so on, the risk would be higher. And then she has lymphedema, and lymphedema itself increases the adiposity that will be deposited on the arm, and it's like a snowball effect that keeps growing and growing and growing until we have, let's say, stage 2 or 3 lymphedema, and the patient needs either she cannot do anything because she lives in a country where there is no microsurgery for lymphedema, or she does not have access to I don't know, all sorts of other surgical treatment for lymphedema. Either she just tried to lose weight, and hopefully it's not too late. Going further on the breast cancer treatment pathway, it is important to underline that although obesity amplifies radiation, dermatitis, and esophagitis, please mind that weight loss is contraindicated during radiotherapy. And the main thing we do during radiotherapy is to keep the patient as the same as she was in the beginning. So we want the initial CT that with the plan for radiotherapy to remain as accurate as possible throughout the whole 25 or 15 or whatever the number of radiotherapy session would be. We want the patient to be as linear as possible when it comes to total body weight. Regarding anti-HER2 agents, there is no data showing decreased response to them related to obesity, but obesity is an independent risk factor for Herceptin-related cardiac toxicity. And my favorite area, the twilight zone, the obesity impact on antiestrogenic treatment efficacy. Is a goddamn twilight zone, and I will try to explain until the end of this presentation why. So first of all, we have two types of agents. We have, let's say, tamoxifen and fulvestrant, and then we have the aromatase inhibitors, and we theoretically know that aromatase inhibitors have more side effects on the muscle. Okay, so during my PhD, when I started, I thought, okay, tamoxifen is the best thing, we will have the best results, and let's go with that. But my data and other researchers' data showed completely destroyed my assumptions, and we today know that obesity does not influence neither tamoxifen nor letrozole or exemestane efficacy. It decreases both fulvestrant and anastrozole efficacy. And the worst problem is that it amplifies antiestrogenic treatment side effects. And I said the worst impact because these side effects are one of the main causes of treatment non-adherence and discontinuation, increasing breast cancer-specific mortality. And if we have an obese patient that will have even more side effects from antiestrogenic treatment, then simply by helping her lose weight, we increase her chances to have better compliance and less side effects to these long-term treatments. Going further to the metastatic stage, the current data shows that obese patients have a higher risk of developing lung and liver metastasis. And we have no data showing a relationship between CDK4/6 inhibitors efficacy and obesity. But obesity does associate a higher risk of treatment discontinuation during alpelisib treatment by increasing the incidence of grade 3 and 4 hyperglycemia. So, to fix the sarcopenic obesity impact on treatment, we need to carefully take into account and effectively address its causes, and these are two-sided. On one side, we have treatment-related causes. So it's not only that obesity so it's not obesity that impacts the treatment and that's all. Obesity impacts the treatment and the treatment impacts obesity. And the main treatment stages involved in etiology are chemotherapy and antiestrogenic treatment. And I will explain in a bit why I also mentioned breast surgery there. And on the other side, we have patients-related causes. And the main one are patients' nutritional beliefs, emotional eating, low quality sleep, and depression. And let's start with chemotherapy. We know today that, let's say, 2/3 of patients gain weight during chemotherapy. It happens because chemotherapy itself has muscular toxicity. It happens because the stress is high. And it happens because the fruit juicer and the China study book are the usual gifts the cancer patients receive alongside with the histopathological exam. But we also know for more than 20 years that with proper oncology nutrition in place, chemotherapy-induced sarcopenic obesity can be counteracted from day one. And this is an old study, from 2002, that showed that if you have a proper oncology nutrition, then your patient during the treatment will maintain. I don't know if you see how I move it. So we'll almost maintain the weight, but will not lose muscle mass. So muscle mass will be constant and the fat can go down. But if you don't have oncology nutrition in place, then fat will go up and muscle mass will go down. So this is something we know for more than 20 years. Oncology nutrition works. We just have to have it and have it done right. And throughout the years, many oncology... I think someone said something. Please mute yourself until the end of the presentation. I don't think she understands that she's speaking. Okay, I will continue. Maybe she will understand. So I was saying that throughout the years, many oncology nutrition interventional studies proved that we can counteract sarcopenic obesity during chemotherapy administration. And please mind again that in the context of active oncology treatment, the weight loss per se is not the goal. Improving body composition and better long-term eating self-control are the goals. And we also know that sarcopenic obesity is amplified by sedentariness, not by surgery. But to this day, there still are breast surgeons, at least in Romania, not many, but there still are, advising their patients to avoid or to limit physical activity to prevent lymphedema, either based on their clinical practice, either based on old studies that questions the safety of physical exercise after axillary dissection. But many randomized controlled trials prove that that this is not the case, and neither the usual household use of the arm at risk does not increase lymphedema, and neither do physical exercise performed symmetrically with both arms without protecting the arm on the side of the affected breast. And swimming, aqua gym, Pilates, yoga, exercises with body weight, with dumbbells or with other free weights, and even rowing, all are proven safe as they do not generate or aggravate lymphedema risk. And optimally, physical exercise should be supervised by a lymphedema-trained physical therapist until the patient learns how to properly perform these exercises. But even without a physical therapist in place, after the first 6 to 8 weeks after the surgery, please do not advise your patients to be sedentary, because beside our own clinical practice, the studies show that obese ones already become the most sedentary anyway. So there is no need for you to tell them to avoid physical exercise. They will do it on their own. So we need to counteract that. We don't need to say, don't do physical exercise, you will get lymphedema. They will not get lymphedema, and even the obese one will become the most sedentary anyway. So don't help them with that. Now, as I said, the main breast cancer treatment stage involved in sarcopenic obesity etiology are chemotherapy and antiestrogenic treatment. But unlike the fact that we can counteract sarcopenic obesity during chemotherapy, the situation is not so rosy when it comes to antiestrogenic treatment. And I'd like to give a possible explanation of why that is. In my opinion, there are two types of treatment. The one that are administered to the patient, like IV chemotherapy, anti-HER2 agents, surgery, radiotherapy, and the one that the patient has to give herself, like let's say oral chemotherapy. If let's say we have a patient with a triple negative breast cancer patients who did not achieve PCR, and she received the recommendation to take 6 months of capecitabine, or let's say we have a patient, a luminal one, that has to have a long-term 5 to 10 years of antiestrogenic treatment, or a metastatic one under CDK4/6 inhibitors. Many breast cancer patients decide on their own to stop or to not take properly their medication without understanding that this behavior, this non-compliance, is associated with increased recurrence risk and mortality. So the problem is non-compliance, and in our clinical practice, proper oncology nutrition applied from as early as diagnosis was able to counteract chemotherapy, breast surgery, radiotherapy, and salpingo-oophorectomy metabolic impact. And the only treatment-related factor that we could not seem to counteract was the antiestrogenic treatment. And shockingly, from my point of view at the time, the patients with the worst results were those on tamoxifen, which made absolutely no sense to me, because tamoxifen actually has lower musculoskeletal toxicity than aromatase inhibitors, but that was at the time. When we further analyzed the data to better understand what was going on, we saw that patient-related factors highly influenced our intervention efficacy. And to briefly tell you what we found that patients with excessive vegetable intake who developed de novo thyroid disease after breast cancer diagnosis, and those with sleep disturbances had worsened sarcopenia. And I think I did not mention statins on this presentation, but they double up the musculoskeletal and hepatic side effects of antiestrogenic treatment. patients on statins during the antiestrogenic treatment, and those with depression in our clinical practice had had a lower fat loss. So the intervention was not effective in their case, and the worst results were obtained by the younger patients. And I'd like to comment a bit about non-compliance. The studies that analyze non-compliance show that between 23 to 50% of patients do not respect oncologist recommendation about how to properly take their antiestrogenic treatment. And many patients are non-compliant with taking medication, any medication. And we have an analysis on 20,000 breast cancer patients showing that patients that were non-compliant to medication administration before the cancer diagnosis have twice the risk to be non-compliant to antiestrogenic treatment administration. And in my clinical practice now, I am absolutely convinced that non-compliance is a mindset. And the luminal patients that have compliance issues in general with taking medication or with whatever are also non-compliant to oncology nutrition recommendation and have a higher risk to gain fat during the years and years and years and years of antiestrogenic treatment. And now going to the patient-related factors that cause sarcopenic obesity. One of the main ones is what they learn from Google University. And what they learned there is that they should not eat meat or sugar and that they should not drink milk. Why? Because the China study says so. And because of the high popularity of this book, the first question I hear during my oncology consultation is, can I eat meat? I mean, I have cancer. How can you tell me that? Why I can eat chocolate? Are you crazy? I came to the wrong nutritionist. So leaving chocolate aside, we can talk about it in the end, that the question. And please, if you have questions, ask them. I will try to answer them after the presentation. I would like to just say that we have many animal proteins and many vegetal proteins, and after intestinal digestion, the only difference between the ones is that the vegetal ones don't provide all essential amino acids. That's the only difference. So after eating an animal protein, we have all essential amino acids. After eating only a single vegetal food, we have some essential amino acids. But when we combine and when vegans or vegetarians eat the complementary vegetal foods, they are recommended to gain all essential amino acids. We actually have exactly the same metabolic impact as when we eat animal proteins. So if animal proteins would be carcinogenic, why would combining vegetal proteins recommended to vegetarians not be carcinogenic if they bring the same essential amino acids? And the debate seems high, but it's not, because if you actually look at the data, even the epidemiological analysis, anyone who has heard of the China study maybe has also heard of this. It's the diet, lifestyle, and mortality in China. It's famous among breast cancer patients and frequently quoted by people advising against animal protein consumption. And this analysis actually indicates a small correlation between animal protein and overall cancer-specific mortality, with a 3% increased risk of dying from any cancer, and a bit higher correlation between eating vegetal proteins and overall cancer-specific mortality, with 12% increased risk of dying from any cancers. but these are correlations, not causes. And also, contrary to the viral hypothesis that animal protein feeds the malignant cell, even the results of the very, very famous vegan biochemistry professor Colin Campbell show that casein intake has a very beneficial intake. And in his study, he showed that mice that were fed 20% casein had better results, not those that had 5%. And this was not surprising at all, as he showed in another study of him that the aflatoxin is much more carcinogenic if the protein intake is too low. He ignored his studies, and despite his life of militating against animal proteins, the only association he could finally sustain had nothing to do with animal protein, but with cholesterol. Plasma cholesterol in the ranges of 90 to 170 milligrams per deciliter increased cancer mortality. Foods of animal origin contain cholesterol. Foods of plant origin do not contain cholesterol. Thus, even bites of animal-based foods are associated with increased risk. And while reading this official statement of his, I will recommend my cancer patients to avoid animal protein when I will meet a healthy human with a total cholesterol below 90 milligrams per deciliter, which I didn't until this day. Despite the fact we have scientific data showing that eating unprocessed white or red meat does not cause breast cancer, and we know from as early as the 1952 that milk proteins have anti-carcinogenic effect, and that consuming milk and dairy foods during oncology treatment is associated with increased survival. And we also know that consuming milk during chemotherapy is associated with less side effect, less fat gain, better muscle mass maintenance during treatment administration, decreased hyperglycemia, insulin resistance, and reactive diabetes. It improves lipid profile, and it decreases the risk of cardiotoxicity. There is no way to tell the patient during chemotherapy to not eat milk, to not drink milk, or to not eat cheese, or to not eat, I don't know, yogurt or labneh in your country, which I also like here. Still, the main food patients associate with estrogenic impact are milk and dairy, but their estrogenic impact is extremely low because 95% of the estrogenic in milk is inactivated at intestinal level. And when I've done my master in nutrition, I evaluated this supposed estrogenic impact with my food toxicology professor, and you can have here the steps we did one by one. And for instance, to generate an estrogenic impact, a woman with a total body weight of 60 kilos should drink around 38,000 liters of milk per day, which is absolutely impossible. So in humans, because we have estrogen in milk inactivated at intestinal level, there is no way that this type of food can have an estrogenic impact. Now, the two interventional studies that try to prevent breast cancer recurrence, excuse me, I lost my voice, showed two things, very important studies in oncology nutrition. They show that eating 5 vegetables and fruits per day is absolutely enough to associate I speak a lot every day, so sometimes I lose my voice. So if you respect the 5 a day, 5 a day is something very, very common these days. I mean, in America, it's really high. If you have 5 fruits and vegetables a day, it's absolutely enough to sustain oncology treatment efficacy. You don't have to go further than that. And I would like to underline that the WELL trial, they use a low-fat diet, and they included patients who they ate 5 vegetables servings per day. These patients also drank half a liter of vegetable juice. they also ate 3 fruit per day, and they got nothing. This patient with all this high fruit and vegetable intake and low-fat diet got nothing better than the ones that just respected the 5 a day. Just tell your patient, count your fruits and vegetables, have 5 a day, it's enough. You don't have to go juicing, you don't have to go overeating fruits and vegetables. This will help you for nothing. And the other thing that I found very, very important is that because I adjust my recommendation based on immunohistochemistry, not only on treatment stage. I have some recommendation for luminal patients, I have other recommendation for triple negative, and I have other recommendation for HER2 amplified. And the low-fat diet has no beneficial impact for patients with estrogen receptor positive tumors. And the data we have up to now shows that low-fat diets are effective only in patients diagnosed with estrogen receptor negative tumors, be them HER2 amplified or triple negative. And we really don't know if this also applies to the lower than 9% estrogen receptor positive tumors, but as we usually treat these as triple negative, we extrapolate the low-fat approach to them as well. But this is really advanced, and if you will have an oncology dietitian that is trained in breast cancer, that this is how you do it. This is how you personalize oncology nutrition based on immunohistochemistry, and if you do it, then you get better results during treatment. And still, it is not only about fatty acid intake, but also about de novo lipogenesis, the main substrate for de novo lipogenesis being fructose. And as I said, many patients go high on fruits, and excessive fruits intake generates liver steatosis, dyslipidemia, and insulin resistance, aggravated obesity. So we really need to understand that fruits are normal foods. They not like I ate an apple and it's like nothing happened in my body. I ate an apple and something happened in my body. And if I ate 1 apple or if I ate like 10 of them, it's completely different story. So we need to advise moderation even when it comes to fruits. Another problem that we saw in our clinical practice is excessive vegetable intake, and I could talk about it until next month about it. But since we kind of run out of time, just know 2 things. First, humans are not cows. We really need to know that. We are not cows, and we do not have the digestive enzymes needed to digest cellulose, and that too much fiber can cause bloating and even constipation if the patient is sedentary or if she doesn't drink enough water. And the second thing I would like to stress about too much vegetables is that they contain nitrate. And you have here a small thing, it's called the sodium iodine importer. And through this gate, iodine enters the cell. And here, if you have a lot of nitrate, you will have nitrate, not iodine. And you can have iodine in the body, but it cannot enter in the cells that need iodine. And we have the thyroid, we have the breast, we have the retinals, some of the retinal cells, and we have the muscle cells that actually need this iodine to enter the cell. And if we have too much nitrate because the patient eats too much vegetables, then this process doesn't happen. And in our clinical practice, 1 in 4 patients that practiced excessive vegetable intake developed thyroid disease because of this mechanism. And we published this data. And what I would like to say is that the patient that actually developed this thyroid disease gained more weight than their, let's say, counterparts that had normal vegetable intake. So again, please recommend moderation, not extremes. And the problem with extreme recommendation is that this can generate or amplify stress-induced emotional eating. And I will try to not go into too much details, but I will still explain this so you can understand. Yes, I will finish in like 10 minutes.
10 minutes?
10 minutes? I have five?
Yes.
Okay, then I will not tell you this. Okay. We can eat for hunger because the blood sugar went too low. We can eat for pleasure because I just like the food, or we can eat for nothing, neither for pleasure, neither for hunger. This is called emotional eating, and it highly aggravates obesity. And the problem is that, like any other stress coping behavior, it gradually leads to tolerance and addiction. And the more stressed you are, the more stressed you are, but I will not go into details here. And one of the first signs of stress is disturbed sleep, which amplifies sarcopenia and undermines their dietary efforts to reduce adiposity, leading to increased hunger and less fat loss. And we actually published a study that showed, it was a small study that showed that sleep quality can be increased in breast cancer patients, but
please, when you open the door, don't leave it all wide open, just close it. Okay. And you need the light with you.
Okay. We cannot count sleep quality impact in patients who are depressive. And
but it's in the back of it, so you need to take them, but in front of you there's lots of sharp things, so be careful.
Sarcopenic obesity increases the risk of...
Yazan, mute your phone.
Okay. So I highly recommend that if you have a depressive patient, to work with a clinical psychologist, and sometimes we also need a psychiatrist because the stress impact on the treatment is complex. And this is like the last slide. To picture the stress complexity, please know this. Stress is not a vague concept, it's a scale. And we have affective disorders, usually between me, and the others just are the last drop in the bucket. Then we have sleep disorders, then we have osteosarcopenia, and then we have emotional eating. And this is important to understand, because if you take a minute and assess where you are on this scale tonight, whatever the step on which you find yourself now, to step up your stress down, you need to fix all the lower ones, and just the same with the patient. So if I have, let's say, a sleep disorder, I also have to go to the psychologist to see what's going on there. And the last slide is to help the patient. Just bring her two things: adequate information and a constant plea for moderation. Please do not incent extreme behavior. Thank you.